Hello and welcome to 9 Months, India's first and only comprehensive show about pregnancy. My name is Meghna Pant. Now when I found out that I was pregnant, I was obviously overjoyed, but I have to admit also very overwhelmed. As a first-time mother, I didn't quite know what to expect or to anticipate. If you're on the same boat, then do listen in, because I'm joined by two renowned doctors, Dr. Nozer Sheriar and Dr. Dhrishti Bijlani, who will talk to us about how to navigate that very tricky first trimester. So Dr. Sheriar, Dr. Bijlani, thank you so much for joining us here in this very special episode on the first trimester. Dr. Sheriar, I'll begin with you. So what are the earliest signs that someone is going to be expecting? You know, we of course have heard of the home pregnancy test.
Well, nature has been doing pregnancies forever.
Yeah.
So nature decided to tell a woman she's pregnant much before pregnancy tests were invented.
Okay.
So the first sign that a woman realizes that she might be pregnant is if she misses her period.
Yeah.
And there are the reasons for that as well. But if a woman misses her period, this is the first thing I think she should think about.
Right.
Then there are certain physical signs that she might feel, sometimes even before she misses a period.
Yeah.
Well, some women may experience a certain degree of nausea,
Yeah.
sensitive breasts,
Okay.
frequency of urination,
Right.
feeling a little lethargic, tired, maybe sleepy.
Okay.
And then she probably wonders, I'm not feeling like I normally do, what could it be?
Yeah.
That's when women might probably resort to a pregnancy test. Now, basically the pregnancy test is a urine test which assesses the presence of a certain hormone in the urine called human chorionic gonadotrophin, which is basically the hormone that we know the woman is pregnant with.
Yeah.
It is the signal that the pregnancy sends to the woman saying, hey, I exist,
Yeah.
you're pregnant.
The ATG
And then
levels,
that hormone
Yeah.
in part goes ahead and supports a structure in the ovary which releases a hormone called progesterone.
Yeah.
Now these are things a woman can kind of do herself. She can do a pregnancy test at home
Yeah.
and find out she's pregnant. But in a controlled situation where a woman is under treatment and where she decides that she wants to know early, or if I have a person who wants to travel somewhere and says, Doc, how do I know I'm pregnant? Because I want to decide whether I can travel or not. You can do a blood test for the pregnancy,
Right.
where you do the serum beta HCG, which actually comes positive almost a week before she misses her period.
Oh, okay.
So she can actually see the pregnancy happening or not happening much before she misses her period.
Okay. But the minute you find out, how soon should you schedule your first prenatal visit?
Well, I think a woman should go to see her doctor, caregiver as soon as possible. Get yourself, your history taken, your examination done, whatever tests the doctor wants done. And that way you will find that you'll have someone there with you who will be with you every step of the journey.
Okay. In all of this, what then makes a pregnancy high risk?
Well, there's no pregnancy without risk.
Okay.
Okay. You can't take a road journey without risk.
Yeah.
But then you could make it a high risk road journey if you start doing dangerous stuff.
Of course, yeah.
So a condition which puts the pregnancy at greater than normal risk would be a high risk pregnancy.
Okay.
It could be the woman's age. She could be elderly.
Yeah.
Though we have
In
lots
India, it's
and
said about
lots
33
of,
or
you know what, it's still 35, it's still 35,
35,
but I have dozens or maybe over 100 women with pregnancies over 40. That's we are changing.
Yeah.
It could be her obstetric history,
Yeah.
multiple pregnancies,
Right.
6 previous pregnancies would put her at risk.
Okay.
It could be certain medical conditions.
Yeah.
It could be a woman who's hypertensive or diabetic or overweight
Okay.
or anemic or has a thyroid disease, which make it a high-risk pregnancy.
Okay.
It could be a woman with previous pregnancy problems. It could be a woman who's had all these things in a previous pregnancy or had a cesarean or an operation in a previous pregnancy or lost a pregnancy earlier or had bleeding in a previous pregnancy.
Okay.
It could be a woman with fibroids in the uterus or an ovarian cyst. At the end of the day, you have to watch a pregnancy carefully because it might start off as a low risk pregnancy, but by the time you through it, you might pick up a high risk factor.
Dr. Bijlani, if a woman does decide to go through with the pregnancy during the first 14 weeks, which is the first trimester, Are there any foods, drinks, lifestyle choices that she should avoid?
Well, we know that the first trimester is very important because that's where all the growth and development of the fetus occurs. So, of course, to generalize it, food from all the food groups, that is your carbs, proteins, etc., all that is needed, good amount of fats as well.
Yeah.
But there are other things like iron and folic acid, calcium, which really need to be looked upon.
Yeah.
When it comes to iron, I think the mother's needs increase. So hence that can be bought through her leafy green veggies or her legumes. While folic acid, very important for DNA synthesis, RBC development in the fetus. But we also know that all this is not easily got by all the food sources. So I think supplementation is very, very essential. And what she should not be eating, what I would call it the 3 C's. That is coffee, cola and Chinese. Chinese mainly because of the Ajinomoto,
the MSG,
MSG. And otherwise I think she really needs to focus on all nutrients that are got from all the food groups. You can't go on a binge spree. You know, I am sure that this is
levels.
I think with a lot of supplementation you lose your taste, you know, something called as dysgeusia, which I think many women experience, and it's very, very common. So of course you can binge once in a way, you can probably make your little one have that little taste of junk food, but you can't make it an everyday thing.
I think the message that is coming out here from her is there has to be balance, you have to be reasonable, and she said it very rightly when she said you can't binge all the time.
You can't binge.
Okay, don't feel guilty with what you do once in a while. Try and be healthy most of the time. And I think the most important thing that people have to do is seek expert advice. If you went to a dietitian who would give you guidance to fit your needs and your likes into what you're supposed to be doing, I think that would be the best way to go about it. And there is no pregnancy of mine who gets away without meeting a dietitian once, and maybe more than once in pregnancy. I see it works great. One, I can get ideal weight gains, not too much and too little, or too little. If I have an overweight patient, I've actually had pregnancies gaining 0 kilos or even minus kilos because she doesn't need to put weight thanks to the dietitian. And you have patients who would be able to gain the right amount of weight. Please bring in specialist help. We are not all qualified to do it. You are not qualified to do it. Here is someone who's a specialist who can guide you with something like this. Please seek help. If you can go to a specialist obstetrician, you should go to a specialist dietitian. And the second person my patients have to go to is to the dentist.
Oh, really?
Absolutely. Every pregnant woman must see a dentist at least once in a pregnancy. Check, clean up, fix whatever is there. It's going to be many, many months before you're going to find time to go back to them.
That's good advice. I should eat it as well. But for me personally, you know, does it deprive the fetus of nutrition in the first trimester if you are so nauseous that you can't actually eat healthy food?
No, I don't think so. Of course, as Doctor rightly said that, you know, you need a dietitian advice. I would also say that I alone cannot work with a client. I also need the doctor, you know, on board to know many things. And where nausea is concerned, as I said, she has to keep a balance. And when again we can correct that. You know, for instance, instead of telling her only have lemon water when she doesn't have taste or she's feeling nauseatic, I would rather tell her, okay, have half an apple. You know, that also works really well. So we'll make sure that we don't deprive the fetus of any nutrients, and that's what we do. We just balance it.
So Dr. Sheriar, you know, almost 15 to 20% of pregnancies unfortunately end in miscarriage. And again, there's a lot of myths, a lot of misconceptions surrounding that. Is there actually any way that women can prevent a miscarriage or an ectopic pregnancy?
I think miscarriages and ectopic pregnancies are inevitable in a certain percentage of patients. 10 to 20% for miscarriage, depending upon what you're using to test for pregnancy, and maybe 1.5 to 2% for an ectopic pregnancies. But theoretically, if you went back for an ectopic pregnancy, predisposing factors are things like pelvic inflammatory disease, and if you manage to prevent those, maybe you might be able to prevent ectopic pregnancies. But let's say this is a woman who is now pregnant, she's come to you pregnant, and once she's pregnant, there's not a lot you can do to prevent these two conditions. When it comes to miscarriages and it comes to the first miscarriage, 70% of them are associated with a chromosomal abnormality.
Okay.
So I call it nature's quality control department. And women feel terrible, and you reassure them and tell them, and very often prove by doing a test after you've completed the procedure for the miscarriage, and you show them that this was a pregnancy, not to be, it was a defective pregnancy, and you're better off without it.
Okay.
The ones you can probably do something about are the condition in which you call it a threatened abortion.
Okay.
Where a woman bleeds or a woman has a collection of blood in the uterus, where you still have a viable pregnancy, where ultrasound shows you that the cardiac activity, the fetal heart is beating, the embryo's heartbeat is present, and then maybe you can step in with some support, some care, some medications, and in that situation you might be able to pull some of these pregnancies through. Okay. As far as an ectopic pregnancy is concerned, the whole approach has to be diagnose it as early as possible. We have a dictum in medicine which says, think ectopic. In an early pregnancy, think ectopic. Look for the intrauterine pregnancy. If you're not seeing the pregnancy in the uterus, it's probably ectopic. And when you do that, you can actually manage a majority of these, 9 out of 10 of these medically, without having to go in for surgery.
Okay.
Yes. Okay. And only when you miss them, or when they are large, or when they bleed, do you finally have to resort to surgery. Which is again a good reason why you must go to see a physician early in pregnancy, so that they can identify high risk factors and help you with the risk of abortion and threatened abortion, or assist you with the ectopic pregnancy and an early diagnosis.
Yeah.